So now we're going to go back to, we keep going back to the right rotation. Give them a break after each test though, so we don't flare her up too much. She comes here and she's starting to get the eye pain. I'm going to ask you to hold that for the C2, pull it down. So I want you to look to see if I take the C1 now and I rotate it left, that's rotating left in relation to the two bones. Now, if we look at the ligamentous attachments in this region, the vast majority of the big ones go from the occiput to C2. Tectorial membrane, alar ligaments, the dura. So when you fix the head, you delay the movement of C2. So now we're going to take C1 and rotate it left. Okay, so as a bone, we're rotating it to the left. That's osteokinetic. We must always talk in arthrokinetic terms. So if I'm fixing the occiput and I'm rotating C1 underneath it, which way is the atlanto-occipital complex rotating?
Left. Right. If you move one right, the other's left.
No, I didn't say that. I said I fix the occiput and I rotate the C1 to the left.
That's right.
It's right rotation. But at the AA joint, it's left rotation. So the question is, if the problem is at the atlanto-occipital joint, by increasing right rotation, I should increase the pain. However, at the atlantoaxial joint, I just decreased right rotation by taking him into left rotation. So if the pain decreased, I'm thinking AA joint. Without doing anything else, I immediately rotate the C1 to the right. And I look for that response. If when we rotated C1 to the left, the pain increased, that suggests AO. Now I rotate C1 to the right and the pain diminishes, this will confirm that it's the atlanto-occipital joint. Yeah? Everybody okay with that? So answer me this. If you fully understand it, you should be able to answer this question. When I rotate left, I reproduce the pain. When I rotate right, I reproduce the pain. There's going to be two options.
Acute arthritis, where it's all inflamed, and every motion's going to be painful.
What's inflamed?
If you have acute or traumatic arthritis, then both directions.
We would have seen that actively.
Okay. So you're talking about for just the act.
Yeah. All we've picked up is right rotation gives us this pain.
You said left rotation and right rotation causes the pain. It could be
Of the atlas.
Of the atlas. It could be a hypersensitive atlas.
Very good. It could be a hypersensitive atlas because, of course, it's supplied by the trigeminal nerve. Or
Fracture.
no, I wouldn't say a fracture at this stage. Certainly not an hangman's fracture because we wouldn't be doing this.
It could be a compression fracture.
A compression fracture we're going to have to sort out later. This test won't do it. No, it's either a sensitive atlas or it's both joints affected. That doesn't usually happen. Usually it's one, but if compression is involved during the accident, as I said, the person's going to be hitting their head then yes, you can get both joints injured at the same time. So what I'm going to do now, give him a break for a few seconds, take him back to right rotation just before it causes the pain. I'm going to take the atlas, and without attempting to rotate it in either direction, I'm just going to squeeze it. So if this reproduces their pain again, we have a hypersensitivity that is so extreme. Anything you do to them mechanically is going to cause more pain. This is your first indication that you should be using a collar. Or, as you said, if you have physicians who do not like collars to any degree, then tell the patient to go to bed. But you're not going to get very far if you create or don't control central sensitization. You're just heading for a lot more trouble. So remember, one of the poorest prognostic indicators is where you have the rapid onset of trigeminal symptoms. One of the reasons is people are treated so badly at the beginning that those trigeminal symptoms are never suppressed at first, and they centrally sensitize, thereafter having constant pain. So a collar, to decrease the potential central sensitization, is a small price to pay, and it will probably only be on for 7 to 10 days while the initial acute inflammation settles, and then it comes off. We don't and shouldn't use collars very often, but if we don't use them when they're indicated, then we are going to get a very poor result. Study done by Lance Toomey again, and a guy called Guru Murthy. How's that for a handle? Guru Murthy, over a 2-year period, demonstrated that if somebody had pain and limitation of motion in your initial assessment, you put them in a collar for 8 weeks. They had a similar group which had no collars. There was a significant difference after 2 years between the group that was collared first and the group that wasn't. The group that was collared, far more beneficial, far fewer chronic patients. So just track up that article and give it to the doctor and say, you know, this is what I think is happening. And I think if we don't do it now, it's not going to get better.
Are you talking about a hard collar or a soft collar?
Soft. Just something I can rest their chin on. And still exercise. The only ones that actually stop movement are the emergency collars, and they're so uncomfortable, but they're necessary. But the softer collars, we want to remind them to limit their movement and to rest their chin every now and again when their head feels tired. That's basically it. So back to the point of pain, and I'm going to now resist. Don't let me turn your head to the right. So if I have right-sided pain, I am resisting the right inferior oblique. Hold. And as I rotate left, I'm stressing the right superior oblique. But I have to remember that when I do isometric resistance, I'm also involving transarticular compression, and in the cervical spine at least, translatory movements occurring. So now I just apply the weight of my hands on her head at the point of pain, remember? So you need minimal force. Does that change your pain? If she says yes, then once again we're suspicious of a subchondral fracture.
Change it, making it better or worse, or still worse?
Depends what we're about to do. If you ignore that and just say get on with it, then it's going to get worse. The incidence of post-traumatic osteoarthrosis in this region is really quite high. And why wouldn't it be if we are ignoring some of the key issues that are happening right at the beginning? So then, at the point of pain again, I traction, which is going to stress the inert tissue. If that's positive, there's your second indication for a collar. Pain reproduced by traction of the neck is always going to be the prime indicator for a collar. And yes, I can appreciate the arguments. I've had doctors phoning me and saying, what's the purpose of the collar? Don't want it. Like, just to settle the inflammation, and the argument is, well, they're going to get weaker. It's like, no, they're not. They'll get weaker if it doesn't settle. Okay, they're going to get stiffer. Good. That is the whole point of putting them in a collar. Because my job, and what I'm really good at, is loosening stiff joints up. What I cannot do is stabilizing unstable joints that have not been allowed to repair. So instead of waiting for 2 or 3 years to have prolo, let's let it scar down right now properly and give it some stability.
How long would you wait, just until the symptoms go away? Like, how long would you keep them in a collar, I guess?
Yes, until the test that told me to put them in the collar is negative. And I said that could be days, usually is.
Days-ish, okay.
Yeah. So then you have to decide who's going to provide the collar. Are you going to provide the collar, or are you going to get them to buy it? If you get them to buy it, it's a lot harder to get it off them again. Whereas if you provide it, I know we've still got a few left at the moment, but we tend to buy them in boxes, like big boxes. And it ends up costing you approximately $8 a collar. If you have a patient that has a craniovertebral or mid-cervical spine injury, you are literally going to make thousands of dollars off them. And if you do it well and correctly, you're going to bring all their friends in. So that $8 investment, it's worth it. Because it's so much easier to say, give me my collar back. Fortunately, we don't have to make that decision too often. So really, you need black and white rules. Extreme sensitivity, so that any touching, any movement reproduces their pain. What other treatment are you going to offer? Even ultrasound is going to aggravate those people. So they need time to just settle down. Pain reproduced on traction, definitely a collar, until the pain no longer reproduces with traction. The big if is going to be compression, the subchondral fracture. The best results I think you get from this, you don't see too many of them, but when you do, you've got to realize that project that forwards a year, they're going to have osteoarthrosis in the region. The best thing is to go back to Salter's work. Anybody remember the name Salter? Probably not, because he was a Canadian. Salter was the person who invented constant passive movement. An orthopedic surgeon who tended to specialize in intra-articular injuries, intra-articular fractures. Did his experiments on rabbits initially and then moved forwards to humans. Discovered that if you unload the joint but keep it moving constantly, then the cartilage can actually heal with a fibrocartilaginous scar. The significance of that is the matrix of these two tissues is the same. So nutrition is maintained. Otherwise, what happens is the area of damage, the subchondral bone, the cartilaginous cells on top die off very rapidly. And we start to see a fissure. That fissure, of course, will be increased with movement, increased damage, increased death of cartilage cells, until we reach a point of erosion where the cartilage literally is either thinned or absent, osteoarthrosis. So, I like to think that we're going to do what Salter did. So again, I would be tempted to put them in a collar and use the collar as a form of exercise. So while they're in the collar, turning their head completely pain-free, constantly through the day. Using the collar to maintain the strength in the anterior cervical muscles. Just use it like a spring resistance. So that's ligament joint. No point in putting them in a collar for an acute arthritis. We need them to move constantly in their pain-free range, stimulating A fibers, stimulating the circulation. There is nothing in this instance to be gained by putting them in a collar. But key here, pain-free range. We do not want to centrally sensitize. And lastly, muscle. Push them. If you think that's a muscle, then push them into an exercise program. Muscles, injured muscles, unless you have a hematoma, injured muscles love to be worked and stretched. So this way, logic is dictating the next treatment step that you take, not guesswork. There's a logic to this, where the treatment is based on the presenting signs and symptoms and the pathology. Okay, so let's finish the scan with this and then we can move on.